everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. This episode of the podcast is sponsored by Pearson Ravitz. For many of you, your career is your calling, so don't let an unforeseen injury or accident take that away. Pearson Ravitz, a firm founded by a physician, specializes in disability and life insurance tailored for healthcare providers like you. They understand the risks you face and offer real education and guidance. It's about more than a policy. It's about peace of mind. Head to surgicalergonomics.com/podcast/ and click on the Pearson Ravitz logo to take the first step in protecting your future. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. This afternoon, I'm delighted to welcome as a guest Dr. Claudia Corwin. Dr. Corwin is a clinical associate professor on the faculty of the University of Iowa, Carver College of Medicine. As both a surgeon and an occupational/environmental medicine physician, she has broad clinical experience that informs her public health practice. She currently serves as the Associate Director of Employee Health for the University of Iowa. As a surgeon, her interests include ergonomic challenges in the operating room, as well as on the disparity in injury reporting among physicians compared with other healthcare workers. Her public and global health interests are focused on occupational health and well-being of vulnerable working populations, including mobile, migrant, and immigrant populations. Dr. Corwin, thank you for your time today and welcome to the Surgical Ergonomics podcast.
Thank you, Geeta. It's my pleasure to be here with you.
Wonderful. So as we start out on today's episode, Claudia, I was wondering if you could share with our listeners your journey. I know some of it and it's very interesting, but I'd like them to hear what your training background was, where you grew up, and then how you kind of landed up in your current role.
Certainly, my pleasure. So I am originally from New York City, so I'm a bit of a transplant to Iowa, but I feel like I've earned the rank of native because I've raised my kids here. So I think that gives me a level of permanence in the state. I originally trained in surgery, general surgery at State University in New York in Kings County, Brooklyn, which was basically a trauma center, and came to Iowa after that to do a fellowship in transplant surgery. And I did transplant surgery at the University of Iowa for over half my career. I had always been really fascinated and interested in public health. But in those days, the general guidance was that surgery and public health weren't really compatible as sort of developing your public health interests as a surgeon. That's changed, obviously, a great deal. But in those days, it was not really an obvious career path to leadership. And so I kind of tucked away my interest in public health and became a transplant surgeon. And that's what I did. And that's what I was happy. My public health interest reawoke, though, when I was invited to serve on a new committee for the Iowa Medical Society, which was a new committee on public health. And through that, I started to network a lot with people who were doing public health on a state level. And I decided to go ahead and pursue my master's in public health. So I was getting around to it a bit late, but better late than never. And eventually, I ended up working full-time at the Iowa Department of Public Health as one of their medical directors. Honestly, it was completely unrelated to surgical ergonomics. It was as one of the directors of the Bioterrorism Cooperative agreement with the federal government. And during that time, I really wanted to see my way back to clinical medicine, but I wanted to do it with a public health lens. And so I retrained in occupational environmental medicine. And then I joined the faculty at the University of Iowa again, and this
Mm-hmm.
time as an environmental and occupational medicine doc. And in my occupational medicine practice, I practice through a public health lens a great deal. Occupational medicine is kind of like, I describe it as an accordion envelope, and you can
Mm-hmm.
keep it closed and just do clinical care every day, take care of injured workers and workers who get sick at work. Or you can start opening up that folder and filling up the different slots. And that's pretty much what I've done through my career path. And so I have a lot of pretty full pockets.
Amazing. I love that accordion envelope analogy. For our listeners, I want to share that I met Dr. Corwin, over the years, early on when I started at Iowa, and then as a surgeon, and then we were reintroduced with my interest in surgical ergonomics. And I think I reached out to you when I was sort of giving our first grand rounds 5 years ago on this topic. And then we've been part of numerous panels, and you were also sort of part of the initial surgical ergonomics interest group that then became the Society of Surgical Ergonomics. But I really wanted to have you on this podcast because, well, one, for your entire sort of breadth of knowledge and expertise, but also for your unique journey that you just described. I don't know of any other occupational medicine physician who actually has been a surgeon and understands sort of the fears, the nuances, the work restrictions, etc., how they apply or don't apply to surgeons and other workers in the operating room, such as nurses and scrub techs. So we're going to spend the rest of this sort of episode learning from your expertise. So tell me now, when you came back as an occupational medicine physician, how did that interest in sort of ergonomics continue? How did it find a new place in that accordion folder of yours? And how do you apply it now on a day-to-day basis, I guess?
Yeah. So as an occupational medicine doc, I wanted at some subconscious level to try and combine my past, my surgical past with my
Mm-hmm.
occupational medicine future.
Mm-hmm.
And it's that thing that once a surgeon, always a surgeon. I think there's something that draws you to the field and sustains you in it, and that really never goes away. Honestly, I was listening to or reading a blog of women surgeons.
Mm-hmm. Mm-hmm.
And these surgeons, these women were taught, and I was already doing occupational medicine. I was sitting at my desk, and these women were talking about hand and wrist pain.
Mm-hmm. Mm-hmm.
And they were describing using all the laparoscopic instruments that were made for men's hands.
Mm-hmm.
And it just, it clicked for me. I was like,
Mm.
oh, I understand this. Like I know what they're experiencing, these
Right.
sort of functional difficulties in the operating room. And I began to get interested in it, and I started to reach out and just sort of do some information gathering with some of our public health colleagues, my public health colleagues in the College of Public Health, and specifically those who work in ergonomics. And
Mm,
we were introduced to each other right at that time period.
I see.
And that's how it clicked. That's how it clicked the first time.
Got it. Now, you've been doing the occupational medicine physician role for some time. From your side as that physician, how likely are surgical procedural personnel, and I'm including surgeons, nurses, scrub techs, likely to get injured on the job and specifically get these work-related musculoskeletal injuries that, we've been talking about?
Yeah, it's very interesting. So I'll say that this is sort of an issue that just sort of bubbles under the surface. It sort
Right.
of simmers, right?
Hmm.
It's not a heavily discussed issue among surgeons or
Hmm.
among practitioners. I think people experience the difficulties in silence or in isolation. But the truth is that proceduralists,
Hmm.
surgeons and
Hmm.
surgeons, have very high rates of musculoskeletal pain.
Mm-hmm.
And most of this data, as you know, Geeta, is survey data from the
Right.
literature, right? But if you look at the data and then you compare it to some better documented professions like construction workers
Mm-hmm.
and
Mm-hmm.
manual laborers, you see that the prevalence, at least, is on par, if not more impressive, but certainly on par. And so, of course, most of this is survey data, and people may look askance at survey data sometimes, but the bottom line is if you put 100 surgeons in a room,
Mm-hmm.
you ask them how many of them have neck pain or shoulder pain or back pain, it's going to be a surprisingly high percentage.
I couldn't agree more, which is why we're actually doing this podcast and we have the Society of Surgical
Right.
Ergonomics. It's a silent problem for sure. People do face isolation, and it's almost like we're things are stigmatized, so you don't want to discuss this. But I think things are getting better. I think surgeons are sharing their stories, and actually, I'll refer our listeners to a previous episode by Dr. Paul Fedak, where he talks about the impact that these injuries have had
Mm.
on him as an individual, both at work and outside of work. So you're spot on when it comes to that. The data that you mentioned, the prevalence rate among sort of construction workers being about the same as surgeons, or surgeons being similar to construction workers in terms of prevalence of work-related pain. I have this information on a slide and I quote that study whenever I'm giving a talk on the topic. And it came as a shock to me when I first saw that study, and I think it comes as kind of a shock to people in the audience because we don't traditionally think of surgeons as being prone to work-related injury and having workman's comp
Right.
kind of cases, right? Worker compensation. In fact, since you mentioned a blog, I have to point out I saw an article on Doximity a couple of weeks ago, and the comments section of this article was more telling than the article itself. And somebody in that comment section said, yeah, surgery, blue collar job disguised as a white collar job. And I think that was particularly relevant to the topic of ergonomics. Right. So let's come to, let's say, an injured proceduralist OR worker. What actually constitutes an occupational injury? And what are the elements that you have to take into consideration to figure out if something is related to the day-to-day work of a proceduralist or an OR personnel?
So I think I'll start by going to OSHA.
Okay.
Because as occupational medicine docs, we think about OSHA a lot.
Yes.
The OSHA guidelines are comprised of standards. There's a standard with what is defined as a work-related injury,
Mm-hmm.
and it's standard 1904.5. And it states that an injury or an illness is work-related if a work event or exposure caused or significantly contributed to the injury or the illness. Okay, that's not very specific, but
Right.
there it is. It's in OSHA. The things that one would take into account to determine if something is work related are things like, number one, first of all, you need to know what the worker really does.
Right.
So when you're doing a good history, occupational history, you don't just want a job title.
Mm.
You want to know what they do
Mm-hmm. Mm-hmm.
and often dig into where do they stand? How's the ventilation? How high are the tables? Like you really want to get into the details of their workstation and their
Mm-hmm.
experience on their shift. And then the other thing is you think about is the temporality of
Right.
of the injury and the exposure or the work event.
Mm-hmm.
So the exposure or the work event, injury event,
Mm-hmm.
have to precede the injury or the illness,
Right. Right.
or have to at least be timed in a way that it's plausible. So,
Mm.
for example, a laceration or a burn, that is a point in time when that injury, when that exposure occurred and when that injury event occurred. It gets more tricky with the kinds of things that we're thinking about on this podcast, which are musculoskeletal injuries that may have a result from repetitive motion or long-term behavior or mechanics in the operating room.
Right.
Because then you end up with chronic shoulder problems, wrist problems, neck problems, and discussing and pinpointing temporality becomes more difficult.
Right.
Then you have to think about plausibility. Is there data in the literature that says that exposure X is related to, in a causal fashion, disease X or Y, or illness X or Y, or injury X or Y? So plausibility is very important. It's important that you're able to have some grasp of the literature, or at least know what to dig into and what to research. And if it makes scientific sense. So temporality and plausibility are very important considerations. And it takes quite a time to really have a detailed occupational history to get that information.
Absolutely. And I'm guessing that, pictures and videos are probably helpful as well, right? Where you kind of watch the worker, what they're doing, right?
Right, right. And in our field, and definitely in our training, we go into the various workplaces all the time
All the time. Yeah.
and look and get a sense for different work environments. And are the floors slippery? How's the hygiene? How's what we call housekeeping in the
Right.
facility? How's the noise level? Are people wearing their hearing protection?
Are they wearing their lead when they're
Are they wearing their lead?
lead? Yeah.
Exactly. How is the camera position in the operating room? Do they appear to be in awkward positions for
Positions.
sustained periods of time? These
Right.
are all things that we would look at.
So I just want to point out to our listeners, the importance of what Dr. Corwin has just shared from kind of an ergonomics injury perspective, right? So a laceration or a burn, or if a worker slipped on a wet spot in the OR and sprained their back, these are all points in time temporarily related. It's much harder to show temporality and plausibility for two reasons for these repetitive strain injuries, because they occur over time and other things you do outside the OR can contribute to them as well, right? And when we look at the plausibility, there is data to show that, but it would be much stronger data if surgeons actually reported their injuries. We know that compared to a lot of other professions, healthcare workers and surgeons in particular, I think nursing does better in terms of reporting their injuries. Surgeons, not only their MSK injuries, but think about the number of times surgeons get stabbed in the OR and don't go and report, right? They don't go and report every single time. You have to keep these elements in mind and remember, if someone's looking to do some studies, we need to figure out ways to get surgeons to report so that this data is available when surgeons are so badly injured or proceduralists are so badly injured that they need help from occupational medicine and have evaluations from occupational medicine. So, Claudia, now you're seeing a worker, you've looked at what they're doing in the operating room, you're seeing a proceduralist, and you think their injury is caused by their repetitive work has led to this MSK injury. Maybe it's kind of wrist pain and they have degenerative changes there, or maybe it's their neck, right? So what do you do once you establish that? I'm thinking just how would someone look at construction workers? Then the obvious thing then becomes, you get restrictions for work duty, or you get told you can do this or need like to take, you can only work for half a day or something like that. How does that work for a proceduralist, knowing what we do, and for nursing and scrub personnel in the OR?
So it's very difficult. So
Yeah.
when someone comes to me, let's just say it's an Amazon box folder, and someone comes to me and they have wrist pain. I will say, I will limit, and they say, I fold 500 boxes a day, let's say. I will say something like no repetitive wrist extension or flexion for 50% of their shift. No lift, push, or pull with the left hand more than half a pound. Must wear brace while at work, these kinds of things. And then the employer will decide if they
Mm-hmm.
have work for that person. I don't
Mm-hmm.
take them off work unless I need to. I
Mm-hmm.
give them guidelines. I give the employer guidelines.
Mm-hmm.
And then it's the employer then says, we have this work for you, or we have that
Mm-hmm.
work for you, or we don't have work for you.
Right.
It's difficult when a surgeon comes in with neck pain
Mm-hmm.
and they wear loops to perform their procedure.
Mm-hmm.
And the restriction that you would give the next person who had a job that required, nearly constant flexion of the neck would be no repetitive or sustained flexion of the neck. Now I'm going to give this transplant fellow
Right.
who wears loops, and I'm going to say to her, no sustained flexion of your neck for more than 10 minutes per hour, let's just say.
Right.
Now she's got to go and
Mm-hmm.
tell her boss
Right.
that she can't flex her neck for sustained periods of time.
I'm just imagining that conversation in my head, and it's not pretty.
Exactly. On that end, that's difficult. It's also difficult for me because
Right.
I know what that conversation looks like. I know exactly what she's doing in the operating room.
Right. You know
I
that all too
know that
well. Yeah.
when you've just sewn in a kidney and you need to vascularize that kidney, like there's no time that you can just take a break. And so it's a little difficult for me to figure those restrictions out because it's almost like a case of knowing too much, right?
Right. Right.
So the bottom line is it's very difficult to assign work restrictions to an operating surgeon who either has his own agency and works for himself, but this is how they sustain their practice. They don't feel like they have the wiggle room to accommodate their own restrictions, or they're in institutional infrastructure that really also doesn't have the room to accommodate someone who needs to be removed from their normal duties for an unpredictable period of time.
Right.
It's very
Right.
difficult. It's very
Right.
difficult.
Right.
And that's if the person shows up in my clinic in the first place, which is unlikely.
Most of the time, they're managing with ibuprofen, coffee, Tylenol, whatever they can get their hands on, trying to go for massage, if they can even, get there. So, yeah, it becomes tricky from all angles. I mean, are you able to prescribe work? Is it easier or is it about as hard to prescribe work restrictions for OR nurses and scrub techs?
It's easier. Well, let me put it this way. There's not as much dialogue in the clinic room of, pull and push, like, but I can't do
Hmm.
this, but I can't do that. I have to go to the operating room. I can't take that break. This is what this is going to mean to me. Typically for nursing, nurses' aides, medical assistants, techs,
Hmm.
those staff people, typically, they will accept their work restrictions. They will present them to the supervisors. They will either
Hmm.
be accommodated or told they don't have work for them for a
Hmm.
period of
Hmm.
time until restrictions change. There's infrastructure. It's not uncommon. Supervisors are not surprised. There's a process. There are many precedents. So there's sort of institutional infrastructure to
I see.
handle those processes and dynamics. And
Right.
that does not exist for faculty.
Got it. So, for example, in the OR, if a nurse has a particular restriction relating to push, pull, etc., after talking to you, they might take them off and put them on desk duty if they have that ability. That maybe they're going to manage the OR desk for a little while. Whereas if they don't, they could potentially be on disability, short-term disability, something like that.
Well, it's not necessarily disability, but but the workers' compensation system will provides both
I
medical
see.
and financial compensation. And, even if the nurse goes back and they're not able to accommodate her,
Mm-hmm.
then most of the time that nurse will usually not happily, but accept that there is no work for them
Mm-hmm. Mm-hmm.
for
Mm-hmm.
some period of time and come back to clinic and work through this process until they go to physical therapy, they have
Okay.
their interventions until they get better, and then their restrictions can be adjusted and eventually released.
I see.
Surgeon
Right.
typically will have much less confidence in their ability to navigate this system in a acceptable way to them and to the institution.
Agreed. Agreed. So for our listeners, I think you've heard us, if you look at that first episode, Ergonomics 101 with Dr. Susan Hallbeck, right? We talk about the different components of ergonomics, right? So you can deal with it at the worker level by adjusting how they do things, right? You adjust the environment, which is maybe their immediate work environment, changing heights of things or putting restrictions on what they're doing. What we do in medicine compared to industry is different. We tend to try and fit the worker to the job and the equipment rather than the other way around. So that's why we talk about how advances in surgical ergonomics will also require participation of industry to change the instrumentation, etc. But there is this whole other piece that Dr. Corwin has just kind of highlighted for us, which is institutional or organizational issues, right? Because think about it, if a surgeon is in your office, Dr. Corwin, I can imagine myself being there at the worst of my pain. I wasn't thinking, how do I get better? I'm thinking, I have X number of patients already on my schedule. How am I going to get through the list? How am I going to tell my boss that I need time off? How am I going to then figure out a way to come back? When am I going to go to physical therapy? I know that, Dr. Corwin, that you want me to go to physical therapy for my neck, but when am I going to do that when I've got X number of patients in clinic and X number of patients in the operating room? And that's what you're alluding to, right? Like we don't have the organizational infrastructure, most places don't. That then becomes another level of difficulty that surgeons encounter when it comes to their kind of work-related injuries. So let's say I was able to thankfully navigate by asking for some reduce the number of cases I was doing. I didn't operate for a few weeks. We had the flexibility of another colleague who could take over some of my caseload. And it allowed me time to go to physical therapy. I also got FMLA paperwork that then allowed me to take time out and go to physical therapy. So let's say you have a surgeon that did all that and then came back, surgeon or proceduralist, and came back to see you, and they're not really better, right? So I'm using just myself as an example, but it could be obviously anybody that you're seeing. How do you determine when that worker, surgeon, proceduralist, is disabled? I mean, maybe they had a little bit of improvement, they went back to the OR, then they got worse again. Maybe they had no improvement. How do you make that determination that they are disabled?
So what we determine, so there's a difference between impairment and disability.
Okay.
So we are often asked to determine impairments. And impairments are the loss or the abnormality of either an anatomical structure or physiological function.
Mm.
Okay. So, for example, a person who has a burn
Hmm.
will perhaps with burns across joints and let's say burns across both forearms and upper arms, and they have burns and contractures. And they're placed at maximal medical improvement about a year after their burn. The insurance adjuster, the system, may ask for an impairment rating. And
Hmm.
that's a rating, a numerical number that is assigned to that person. And it is something that reflects that loss of function,
I see.
okay, or loss of structure. That is then used for the workers' compensation system to then move through the process of compensation. Disability is more like the inability to perform one's functions of daily life. And a time that we will be asked to do disability exams often are for example, firemen and policemen who come up for disability. And the question is, the ultimate question for that fireman or policeman is, are you able to perform all duties of a police officer or a firefighter?
Mm-hmm.
And if they are not, then they would qualify for their institutional disability.
Mm-hmm.
So it's important to make that distinction between impairment and disability. And deciding impairment is very algorithmic. We use something called the AMA guides, and there are very specific guidance for almost every part of the body. And we use that in a fashion that seems to be very sort of algorithmic and impersonal, to be very honest.
Mm-hmm. So for a surgeon or proceduralist, there really isn't access to workers' comp, right?
There is.
There is. Okay, can you
Yes.
elaborate how that works for them?
It works in the same way. So if a surgeon comes and says, I have neck pain,
Mm-hmm.
surgeon 60 years old, let's say, and
Mm-hmm.
has been operating for 30 years.
Mm-hmm.
And again, performs maybe procedures that require, hyperflexion of the necks. They use loops. Their procedures are 4 or 5 hours long. They do 2 or 3 procedures per day. Then we will go through the process in clinic to
Mm-hmm.
establish causation. And,
Mm-hmm.
the physician will be asked to make an opinion, opine as to whether or not they think that this person's symptoms are work related. And
Right.
it's important to say in this context of this question that the standard is that we don't have to be 100% sure. We have
Oh.
to be able to say, I can stay with a great reasonable degree of medical certainty, or it
Mm-hmm.
is more likely than not that
Mm-hmm.
this person's neck pain arose out of her or his job.
I see.
So we don't have to be 100% certain. We have to use sort of that threshold of certainty. And even having said that, it's not always easy. So if, so a person comes to me and they have, yes, maybe some degenerative neck changes on their X-ray or their MRI, and it's been long-standing. They don't have any other hobbies that would be contributing to this. There's nothing else
Right.
in life that approximates what would cause, this kind of degenerative neck disease, and they clearly have a job that has sustained flexion for many, many hours per day. I would be able to say, I can state with a reasonable degree of medical certainty, or it is more likely than not that this person's neck pain is related to his or her tasks at work.
Mm-hmm. Mm-hmm.
And once the insurer accepts that opinion, they have an accepted workers' comp claim, and
Got
that
it.
workers' comp silo. And unfortunately for us, workers' comp and health, so the workers' comp system and our personal healthcare system, they're in two very separate silos,
Right.
and they don't talk to each other very well. So it's sometimes we have to treat conditions in isolation of the rest of a person's life
I see.
and distinguish, which is not really how a lot of a person's health and healthcare evolves.
Right. But it's kind of
Right,
telling of the entire culture of
right,
medicine, right? Like we work in
right.
silos.
Right.
So, yeah.
Work, exactly. Work
Yeah.
at home affects work. I mean, health at home affects health at work, and health at work affects health at home. And that is the sort of the premise and fundamental of a concept called total worker health that
Right.
is espoused, supported by the National Institute of Occupational Safety and Health.
So, Claudia, as a follow-up to what you just said, I guess I'm going to ask, we are told to make sure we have good disability insurance early on in our careers, get it as soon as you can, and that when you can afford it, so that you don't, have conditions that then end up being excluded, etc. When does that kind of come into play in this sort of, worker coming to you and getting evaluated sort of pathway that we just talked about? When does this come in?
So at a certain point, if after a person is evaluated, treated, all interventions have been tried, that may be physical therapy, medications, it may be corticosteroid injections, it may be nerve ablations, it might be surgery. After everything has been tried and
Mhm.
a person still cannot perform their job,
Mhm.
and we're unable to remove those restrictions, then unfortunately, it comes down to writing permanent restrictions for that person.
I see. So after
And
maximal medical improvement, they still can't perform all the duties of their job.
right, then you're looking at permanent restrictions, which fortunately we rarely end up writing, but it's definitely an outcome of certain cases.
So, Dr. Corwin, I wanted to ask you, from your perspective, both as a surgeon as well as an occupational medicine physician, what advice do you have for maybe students considering a surgical career or surgical residence, or junior faculty who have not yet developed these chronic symptoms that we're talking about? What are some pearls of wisdom that you can leave them with, things that they absolutely need to take into consideration in their early careers so that they don't land up in your office?
I would tell them a few things. The first thing I would tell them is to get early guidance and consultation from a good physical therapist who understands their job.
Okay.
So a physical therapist who understands what it means to do a laparoscopic procedure, would understand the setup in the operating room of where the cameras are and where the screens are and the televisions. And so to get some good basic preventive measures in place. And then the second thing is not to ignore symptoms,
Right.
right? The third thing is not to be shy about talking to their colleagues about their symptoms because they
They're not alone.
will
Yeah.
not be alone.
These were wonderful pearls, Dr. Corwin, and I just want to follow up on one of them that you mentioned, which was, to report symptoms, and who should sort of faculty, or who should the physicians experiencing these symptoms report the symptoms to, and how does it work in most institutions? Like, how does it land up in occupational health office?
So if you would go on to into our intranet employee service, employee
Hmm.
self-service, there is a form and there is a
Hmm.
place for you to do your reporting. And that
Okay.
will be funneled to the proper channels at that time. In other words, you don't have to tell your boss, like if you're a fellow, you don't
Hmm.
have to tell the if you're a radiology fellow, you don't have to tell the chief of radiology you're having neck pain.
Okay. Got it. Good to know.
That's right. That's not the path. It goes through an HR path.
Got it. Okay. Now, unless your institution and program has established reporting for these kind of symptoms, they've built in kind of an ergonomics program, then that's different. But otherwise, you can do a worker self-report of injury just like you
Right.
would if you got a needle stick in the OR, right? Most
Exactly.
systems have that.
Exactly.
Okay. Well, Dr. Corwin, I'm always amazed how quickly the time we've set aside for chatting on this podcast and episodes goes. And so that's exactly what's happened again. So before we end today's episode, I do want to again extend my heartfelt thanks to you for coming on the podcast and sharing your knowledge and expertise and perspectives, both perspectives as a surgeon and an occupational medicine physician, with our listeners. So thank you.
Oh, it's my pleasure. Thank you for having me.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.